It is my great pleasure to introduce a man who I believe has travelled the furthest to be here with us this morning, Colonel Rakesh Jetley. Colonel Jetley graduated in 1991 from the University of Toronto with a doctorate in medicine, and on graduation he was posted to the Canadian Forces Base Borden as a general duty medical officer and flight surgeon. In 1993, Colonel Jetley deployed as the Senior Medical Officer to the United Nations mission in the Golan Heights, and in 1994 he deployed to Rwanda as part of the Canadian Forces humanitarian mission. In 1996 he was accepted into the University of Toronto's postgraduate training program in psychiatry and was promoted to the rank of Major in 1997. Upon graduation in 2000, he was certified as a Fellow in the Royal College of Physicians and Surgeons of Canada and posted to the Canadian Forces Health Services Centre. During his tenure in Halifax from 2000 to 2008, he filled various roles, including Clinical Director of Mental Health Services and Regional Director of the Operational Trauma and Stress Support Centre. In 2006 and 2007, Colonel Jetley was deployed on 2 separate missions to Afghanistan as the head of the Mental Health Detachment of the Canadian-led Role 3 Multinational Medical Unit. He was promoted to Lieutenant Colonel in 2007 and posted to Ottawa, and in 2008 as the Medical Health Advisor to the Deputy Surgeon General. Rakesh was promoted to his current rank in 2011 and appointed Senior Psychiatrist and Mental Health Clinical Advisor to the Canadian Forces Surgeon General. He has additionally been appointed in 2015 as the Canadian Forces Brigadier. He was additionally appointed in 2015 the Canadian Forces Brigadier Jonathan C. Meekins Chair in Military Mental Health. Colonel Jetley was appointed to the Order of Military Merit as an officer in 2009. He's also an Associate Professor of Psychiatry at Dalhousie University in Halifax, Queen's University in Kingston, and the University of Ottawa. He's published numerous articles in professional journals and presents nationally and internationally post-traumatic stress disorder and operational psychiatry. We are particularly delighted to welcome Rakesh to Brisbane and look forward to hearing his presentation entitled PTSD, Setting the Scene, an International Perspective. Ladies and gentlemen, Colonel Jetley.
Thanks very much. Those bios are very long and they just remind you of how old you are, but it has been a long journey to get here, and it's really a privilege to sort of kick off this conference. I mean, there's advantages and disadvantages to going first, so I'm not going to repeat anything that other people have said. I am kind of looking forward to getting off the stage and listening to what Sandy McFarlane and Richard and David Forbes and Stephanie Hodson have to say, because the expertise in Australia is certainly something that we notice in Canada. Going first, I'm not going to talk about the definition of PTSD. I mean, I think that we go quite often and we hear symptoms and see symptom lists. So what I'm going to do is a little bit differently. I'm going to show a video from a short clip. It's a little bit dated from a BBC film called Warriors. Are people familiar with that at all? And it was an interesting show about folks that had been to the former Yugoslavia, just like Canadian soldiers, very similar kind of experiences in the sort of the gray zone between peacekeeping and war fighting that sort of occurs, witnessing atrocities, those kinds of ideas. And I'm going to just show a few clips of sort of the guys coming home. Coming home, it's dramatized, so it's a little bit over the top, but the whole idea of sort of, the re-experiencing that they're having, the triggering that they're having, so the hyperactivity, the avoidance, the anxiety, this kind of idea will just sort of be self-evident, and perhaps we'll keep these kind of folks in our minds as we talk for the next couple of days. So I'll just try to run this if it plays. Just come back.
You find the ingredients of a fruitcake.
You could just buy one.
I'm going to make you one.
Why?
What are you crying for? I've seen kids who've really got a reason to cry. You've got all your arms and legs. Your head hasn't been shot off. Yous. None of yous know. If only yous knew how lucky you are.
Get out of here before I call somebody.
I've seen people on fire.
You should keep him locked up.
I'll make some tea.
I'm sorry, you're missing the match.
I think I care about the match. Are you okay? We don't have to stay in here.
No, like it here.
I'm learning to play. Do you need us?
Yeah, go for it. Really proud of you. How you doing, Alan, lad?
Okay, thanks, Mr. S, yeah.
It's good to have you back, so.
Yeah.
It was a great job you lads did out there.
Yeah.
We're all really proud of you. You were heroes, all of you.
Yeah. I think it was shite. What we did. Leaving people to die.
So I think that's a pretty graphic way of sort of starting off. And I think that as we talk today, there'll be a lot of mention of symptoms, of sort of diagnoses and things like that. But I think it's always important to sort of keep people like that in our minds. Sort of let's put a face to sort of the illness. Now, why Canada for the international perspective? I was kind of curious. I mean, there's two sort of theories, and I haven't had a chance to confirm. I mean, one could be that the Americans said no, the British said no, the Germans, the Dutch said no. So, let's get a Canadian, buy him a couple of beers, and he'll probably do it. But I'd like to think that there was something more to that. And so one of our international colleagues, when he was visiting Canada a few years ago, and for those of us that know him, it's Eric, and from the Netherlands, and he said, well, that's kind of funny. Why do you guys have Australia's Queen on your money? That was a very sort of innocent Dutchism, as we tend to call them. And so it's interesting. And so at one level, it's sort of a funny kind of a misunderstanding. But on another side, it might explain part of why the Canadians and the Canadian perspective and the Australian perspective are sort of so common. And sort of growing up with my sort of background, I mean, like half the Indian movies are twins separated at birth. They come back together, realize one guy becomes a bad guy, one becomes a good guy. So in many ways, I think our stories are like sort of, kids sort of separated and sort of we get together once in a while and we sort of share stories. We fought together the Boer War. Both of our national identities were forged in World War I, and that's really, so we marked sort of Vimy Ridge, Passchendaele, some of these battles are sort of defining Canadian. In April, I was actually in Turkey at the same time as the Gallipoli sort of remembrance. And for you folks, World War II, Korea, and we had no Vietnam, and I think that's sort of, that may or may not be interesting to a lot of people, but it may be significant in the sense that for this whole PTSD stuff, whatever you want to call it, we sort of had to reinvent the wheel, sort of after Bosnia and things. So we didn't sort of dust off what approaches we had in Vietnam. So that may or may not be something we'll talk about. We all did lots of peacekeeping. I mean, some people credit sort of our Prime Minister Pearson for inventing peacekeeping and things like that. We were together in Rwanda when I served there. We had Australians there also. Then back to warfighting again, Afghanistan, and sort of who knows what's going to happen as the future comes along. So I think, it's sort of two countries that have sort of been sort of in parallel for all these years. Similar populations. We're not as big as the Americans. We don't have sort of 50,000 troops sitting in Korea or sitting in Japan at any given time. So we do have to sort of work together as nations and work together to sort of resolve some of these issues. The PTSD story for Canada began 100 years ago, and I think there is a lot of remembrance around World War I, and I think there are good reasons for it. So things aren't new. Back then, just like now we're looking at MTBI and these different kinds of things, there was a search for a real cause of PTSD. Couldn't it just be a psychological one? Shell shock, soldier's heart. Issue for care of the veterans sort of was prominent back then as well. When I look at sort of what the Canadian experience is in some of these battles, I always have to double check these figures. I use them in different slides because the numbers are sort of hard to fathom these days. But at Vimy Ridge, all 4 Canadian divisions fought. Over 10,000 people were killed just in several days of fighting. It's our defining era because we sort of won, and it was the first time Canadian troops had actually been led by sort of Canadian generals and things like that. So it was quite impressive. Another battle, just to sort of talk a little bit about it, Battle of Somme. Now, Newfoundland is sort of, I don't know if it's like our Tasmania, but it sort of wasn't quite part of Canada until the 50s. So when the Newfoundlanders fought in World War I, World War II, they fought under the British flag. And again, 801 soldiers. July the 1st, interestingly enough, is also Canada Day. So Newfoundlanders have a hard time celebrating Canada Day. So they sort of remembrance in the morning and celebrate in the afternoon. But again, 801 soldiers attacked. Within 30 minutes, after sort of the dust settled, roll call, only 68 people responded afterwards. So the numbers are staggering compared to what we experience today. And really in terms of sort of understanding, in my introduction, one of the things that was mentioned was this sort of chair that we've created in sort of military mental health, and it's Brigadier Jonathan Meekins, and Meekins was kind of a rock star of physicians, military physicians back in World War I, World War II, sort of retired as a brigadier. And he was one of the first to study gas and the effects. And back in those days, a lot of the military physicians were physicians of hygiene, and they looked into sort of what kind of things are going on inside people's bodies, infections and things. And he and some of his colleagues had to realize that gas, was a psychological weapon. you're never going to destroy an army with this gas just sort of spreading out, hoping it's going to kill people. Really, it scared more people. It makes people wonder about what's going to happen next. They're going to lose sleep over it. They start to lose confidence in their training and their equipment. So you're going to have far more psychological casualties than gas. And interestingly enough, it's like today's battles of improvised explosive devices, IEDs. You're never going to destroy a modern army sort of by blowing up every 200 vehicles that pass by, but you're sure going to affect a lot of people psychologically with these weapons. So I think people understood a long time ago that there are these mental health conditions that are consequences, and we seem to sort of forget and reinvent and forget and reinvent. So we followed a British approach, sort of a shell shock kind of approach to mental health at that time. Just very briefly, I'll just there's a sort of a letter sent back from a hospital saying to a family member. This is from the Canadian Red Cross. He was admitted to the Alcove Hospital suffering from shell shock, which has affected his speech. But we hope with the proper and usual treatments that this will come right in time. So documented cases of people that were suffering psychologically in war. And care for the veterans became a big issue in Canada, as it did in most of our countries. Demands for care from the veterans. And interestingly enough, at the same time, labor unions and all this was kind of raising. And many of the leaders in labor turned out to be ex-military folks, veterans, and things like that. So it was supposed to be the war to end all wars. It really wasn't. And sort of one of the books that a lot of us that are interested in military trauma have read, Ben Shepard's A War of Nerves, it doesn't, we can't agree with everything that he says, but one of the interesting points that he makes, which I think is interesting, given the forum that we're at today, is with the PTSD issue, World War I, the problem is first denied, then exaggerated, then understood, and finally forgotten. In the ferment of the war, this cycle is speeded up. In the languid, well-funded peacetime of the 80s, it has taken over 2 decades for the wheels to turn. So I think that's the challenge. That's the challenge that we have today, because just like many other generations, we think, okay, we finally got it, it's there, how could we possibly forget it? But I think about 100 years ago, military psychiatrists stood in front of people and said the same thing. I think just after World War II, just after Korea and Vietnam. So the idea is, how do we make a difference this time and try to make sure that we remember this? And I think in 2015 there is a cause to be optimistic. I think that there are things that we can do within our militaries, within our ambulance services, first responder communities, those kinds of things. Cultural change, organizational elements. I'll go into some of the details. I'll focus a lot on the Canadian Armed Forces and what we have done, not in any way to kind of say that we've figured it out. I mean, we've made mistakes along the way. We're sort of struggling with the same things, but just for sort of food for thought, and we can sort of discuss things. I think one of the things to keep in mind, and it did come up yesterday in the pre-conference issue, and I've put a couple of slides together on that, is that many people have said in the past that the only winner in war is medicine. So these horrible things happen, but we do tend to have sort of medical gains that sort of, are led by militaries, led by whether it's military surgeons, those kinds of ideas depending on what it is. And then later on, sort of society gets to benefit. And in World War I, we had, Walter Yeo and Sir Harold Gillis is a British plastic surgeon. And so plastic surgery, he's quite often attributed, in the Battle of Jutland, it was one of the few sea battles of World War I. His face got blown up. German ship sort of hit his ship, and fire burned his face beyond recognition, and sort of flap surgery, the kind of surgery that we'll do every day. So now when you think about sort of a young child that sort of reaches onto a stove and spills hot soup on her face and has surgery, this is part of the advances that sort of military medicine makes. Understanding. So World War I, surgical advances, the whole idea of triage, and really the idea of septic conditions became very important. But there were still 80% of people after abdominal surgery died, and people started to realize that no matter how clean you are, there are going to be infections, there are going to be things that are going to, so how are we going to change if we are going to be in another conflict, this kind of idea. There were no antibiotics, and really the search for antibiotics began after World War I, thinking about how are we going to sort of address this issue. And in World War I, World War II, one of the most amazing things was sort of from the bench work of penicillin to actually using it in the field, it was only 3 or 4 years from mice to people. So if there really is that urgency, We can make medical advances. And one of the main leaders was an Australian fellow named Florey, who traveled to North Africa in 1943 with this miracle antibiotics, and he went in and people were wounded with the kind of wounds where you would by necessity have to amputate the legs and things like that, and gave them this miracle cure of penicillin, and then began sort of the antibiotic sort of generation. Few sort of stories about this fellow again. I think he was from Melbourne, forgive me if I'm wrong, but it's somewhere in Australia. And he flew from the UK back to the US to try to make as much penicillin as possible. So one of the things that the soldiers, when they advanced into D-Day and into sort of Europe in 1944, was to have antibiotics to save lots of lives for those that got wounded. So the golden hour of trauma, so the idea of scoop and run sort of has come from military. So many advances have come, and I think that if it's certainly the Canadian perspective, the way we want to try to think of it is that maybe the winner of this war from a health perspective is going to be mental health. Maybe with the stigma reduction, education, training, resilience, leadership, and I'll talk a little bit about these kinds of things. The DSM-5 I've put down there. I mean, the PTSD diagnosis has changed. I mean, there's some controversy about that. But one of the main things that occurred in sort of our diagnostic classification is there's a section now specifically for trauma that's within the DSM-5, which is sort of the American Psychiatric Association's Bible on classifying illness. And so rather than having it sort of a type of anxiety disorder, now the trauma disorders and people are actually looking at those kinds of ideas. So the idea sort of what Canada has done and what we've done, and a lot of the discussion about sort of the holistic approach, in many ways starts with thinking about things in sort of a determinant of health kind of perspective. And really, for people to be healthy, the health care, the health service that they get is a small part of it. So part of our sort of initial sort of discussion with our leadership and all of this is to try to understand that mental health is a leadership issue, just like physical health is a leadership issue, and not a doctors and psychiatrists, psychologists kind of approach. So looking at employment, working conditions, education, physical environment, social support networks, there's many things that organizations like militaries and sort of certainly first responder communities can sort of have some control over that can impact on people's health. So what we began in about 2000, 2001, sort of prior to the Afghanistan mission, and it was after a lot of investigation and discussion about how we were treating sort of our veterans from places like Rwanda and Somalia and the former Yugoslavia. We sort of had people that came back having difficulties. And where it really starts, it starts at the top with sort of the cultural change. And that's General Natinchuk, who was our Chief of Defense Staff a couple of CDSs ago, who started sort of a Be the Difference campaign, basically charging the entire force to sort of create a culture that encourages help seeking and ensure that help is there. So that was sort of from the top. And those of us that are in uniform kind of know that your boss's priority pretty quickly can become your priority. So that really helped us in that way. It set the expectation for the entire organization. And the leaders, they fund mental health programs. So in tough, economic times of the last 10 or 15 years, the head of the Army, the head of the Navy, the head of the Air Force, all of their departments are taking cuts, but they're solidly saying, but don't cut health. Don't cut health towards our troops. So our funding for mental health has actually increased while other areas within the military have reduced. They fund the research program, they support the outreach and awareness programs that have occurred. I'll give various examples of things. I mean, there's no way in sort of an hour or so that I can sort of go into detail and everything, but just some of the ideas. I mean, we adopted and started to use, and none of the ideas are so uniquely Canadian. I mean, we've worked with the American Marines, we've worked with the Brits, we've worked with the Australians, the Dutch, everybody, and just basically the generosity of the military community is we sort of take things and sort of adopt them. So, we created the term OSI. So it's not a diagnosis, we're still, as doctors, still diagnosing people with the illness. But we created a paradigm, called operational stress injury to describe the persistent psychological emotional difficulties after operation. So that includes post-traumatic stress, that includes depression, that includes this. And the idea was to legitimize the consequences, of these psychological difficulties after war. So you're injured, and the leaders will say that, the doctors will say that, so I think that sort of helped a fair amount in terms of having people come forward. It's not just what's in a name, it's also, truly believing what you're saying. Another sort of concrete example is, we have, I don't know if Australia still have the wound stripe, but, from the British, we used to have a wound stripe years ago. We created a medal a few years ago, sort of similar to a Purple Heart kind of idea. And we had that tough decision. I remember the Surgeon General was talking about it and said, Rakesh, should we give it to people that have PTSD? And I said, we probably should, but I don't think we should limit it to PTSD, because after, you can have other psychological consequences afterwards. And so we created a medal. So if you're wounded psychologically from the enemy action, you receive a medal, the exact same medal that somebody that has an amputation, this kind of idea. So it's a struggle they're having in the US about the Purple Heart, whether they're going to give it. They haven't yet given it. But again, just a concrete example of and there's been times that I've been asked to go to a clinic and actually put it on a soldier. So people actually, we talked a lot about people raising their hands and sort of doing it. So we have awarded many, many sacrifice medals for psychological injuries, in our force. We created a peer support program. Again, operational stress injury and social support. Nothing I've mentioned so far is about medical advances, right? It's about the holistic approach. And so social support, and basically in 2001, one of my good friends, Lieutenant Colonel Steph Granier, who's now retired, sort of, was amazed that they'd give him all kinds of money to sort of travel around the country and have coffee with people, and sort of try to set up that peer support idea so people can relate to other people that are going through the same struggle. So we started with a members approach, sort of people that are, it's a joint Veterans Affairs and Department of Defense program. So it started with sort of members reaching out to members, some guys that are retired but older, this kind of thing, all of whom had suffered. Then we expanded to a family and a spousal program. And then sadly, because we had the need and folks started to die in Afghanistan, we sort of set up the bereaved place so that if somebody loses a spouse, within a day or two, a peer who's gone through the same experience reaches out. So that's sort of a program. They all receive different kinds of training, and some are paid, but a lot of them is a whole network of volunteers out there spread out across the country to reach out. Organizational elements. So again, one of the things to be optimistic about. I mean, one of the things is that to understand the scope of the problem. And I think, we were struggling yesterday with some of these issues, and I'll talk a little bit about what the scope of the problem means. But I think part of what an organization also has to do is that when you consider, a mission or a day-to-day thing, or you're putting your schedule together for the, for the rotations for people, consider the mental health impact of things. Consider what it means when you're telling people that, I need this by noon tomorrow, or we're going to go here and we're going to take only 13 nurses to man a hospital. So think about the day-to-day issues. Enhance the treatment that's available. Make sure that people have access to evidence-based care, timely access, and screening. So many, many organizational elements that can occur as well. So we deployed a mental health team to Kandahar, as I discussed. So we looked at the sort of the type of mission that we were going to have in Afghanistan, looked at the threat, looked at the stress, looked at all these different types of things that people are going through. So we sent, so I went, and we are psychiatrists there. We had, we had psychiatry, social work, mental health, nursing, sort of full sort of mental health team. We don't have uniformed psychologists in Canada, so we had everybody else. And so the types of experiences that people were going through, in our minds, necessitated having sort of mental health resources in theater. And we were busy. We saw lots and lots of different kinds of conditions. There's just in a very simple way of thinking about it, it's 4 sort of large groups. And what was surprising for me was that it wasn't all about trauma. If you stop and think about it, if you take, a few thousand people to Hawaii for 6 months, some people are going to get ill. So part of that's the sort of the base rate of mental illness. But so some people, you'd have pre-existing illness. They may not have known about their illness, but they come into a war zone, they lose their normal supports, normal things, and all of a sudden the disease manifests itself. Some may have known about the illness, thought it was successfully treated, came back and it flares up. I mean, all things can happen. The second large group, emergence of a new disorder. You're talking about young people at an age where these illnesses sort of first manifest. Maybe the tour contributes to it, maybe it doesn't, because, certainly scare people, sleep deprive them, do all these different kinds of things. Maybe, the bipolar illness may come out for the first time in theater. There's trauma-specific presentations, combat stress, acute stress, those kinds of things that sort of come in waves after sort of, the combat missions. And then the fourth one I think is really important that as physicians we're not always sort of trained to think about, but it's the psychosocial issues, marital strife, children. I mean, today's wars are very different because of Facebook and internet, and like get a quick phone call back and forth. I don't know if people saw the film, American Sniper, but the fellow was sort of talking to his wife during contact with the enemy, kind of a scene. And so some of the stuff, the home front stuff that used to be sort of in the past, really comes forward. And if you're trying to sort of run a mission, if somebody's distracted, they're supposed to be, the air sentry and the armored personnel watching for, the bad guys kind of idea. It doesn't matter whether they're distracted because of, they're dissociating as part of their PTSD, having a flashback, or they're thinking there's going to be nobody home when they go home. I mean, it's equally a risk to the mission. It's equally a risk to the person and for all the folks around. So having those resources are there. Just quick, we've all got data sort of looking at sort of, prevalence of mental health problems. So these are surveys that we did while our soldiers were in theater. So they've all been screened, they're good to go, this kind of idea. But we had a full sort of 8% of them still reporting significant mental health symptoms and potentially the need for help and these kinds of ideas. So I think one of the organizational things that we've changed is thinking about sort of the mental health of people as they deploy. For many, many years, militaries have always thought about the physical, the hygiene, what safety, the evacuation routes, do we have surgeons there, this kind of idea. But I think to sort of make the organizational change to have mental health as one of those factors is important. Other things that we've done is we've tried to work with our leaders. We've tried to work with our leaders, and I think that, it's very, very easy to be a general. It's very easy to be sort of a very senior person and say, nothing's too good for our troops. The mental health care is really important. The hard part are the middle management, the senior NCOs, the young captains who they have a job to do. They have a job to do, and we as sort of the more senior leaders need to give them the cover so that they can look after their soldiers. And the idea, I'll often use the example of, somebody that's in financial difficulties, and, in militaries we still have where the creditor can sort of send a letter to the person's commanding officer saying he hasn't paid for his car, this kind of idea. So you can punish the person, or you can give him Friday afternoon off to go speak to his bank manager and try to sort out his difficulties, right? So I think the idea really is to sort of give the middle leaders tools, give them a way to have a chat with somebody, not make them therapists, but just to give them the kind of advances. And in Canada, we've got a whole workplace mental health thing going on in the civilian world as well, where there's training for managers and things like that. So we're jumping on sort of that bandwagon as well. Another organizational thing that I'll spend a little bit of time talking about this, it came up yesterday in our pre-conference discussion. So, we know lots from sports psychology and elite military training about sort of, so-called increasing resilience, not necessarily making people immune from PTSD, but maybe performing a little bit better through tougher times, and maybe they'll seek help earlier, those kinds of ideas. So we've, the Australians who've got Battle Smart, the Americans, keep changing the name of it, but it's now Comprehensive Soldier Fitness. There's lots of different programs. Ours is called Road to Mental Readiness, and we started at basic training. And just to sort of the bottom line up front, as we sort of, what we found as we continue to do research on it, when you give people this kind of training, it increases their confidence in stressful situations, and it also increases help seeking if they're running into difficulty. So that's sort of a perfect kind of outcome for this kind of training, and we sort of continue to look at this. And I'm going to go fairly quickly through these slides, but just the idea of sort of the, how it's sort of evolving over the years. And we started right at the recruit level. So every officer and every enlisted that joins, because when you're 17 years old and you join the military, and all of a sudden people are telling you to dress a certain way and cut your hair a certain way, those few weeks or months of basic training is actually the most stressful thing that you're going through at that time. So it helps people to sort of get through there. And then we have sort of every point where you go take sort of leadership and you're going to be responsible for other people. We increase it there also. And then we do a lot sort of around deployment as well, so before deployment. And the important thing about it is that it's for the members and it's also for the families as well. So when people are coming back, we're giving them training in Cyprus on sort of, hey, just because you've made through the mission, there's still sort of a few challenges when you get home, but we're also giving the spouses the same kind of idea. So I think it's, we're quite happy with how it's sort of evolving. Try to keep it simple. We take sort of the sports psychology kind of stuff, sort of, the big four, just talking about sort of goal setting, visualization, self-talk, tactical breathing. And if you think about how basic these things are, and as we're working, we're trying to get more and more in the civilian world, we'd like for this to be in schools and things as well, is if you imagine sort of a top athlete, a gymnast, or somebody that's about to dive and about to do sort of the Olympic event or whatever, that when they're standing up top, they're sort of the goal setting, they know about their dive they're going to make, they're closing their eyes, they're visualizing themselves do it. Their self-talk is sort of like, I've done this 1,000 times before, I can do this, I can do this. And then tactical breathing, they're controlling their breathing. So it's really ripped right out of performance psychology, sports psychology. And the soldiers like it. That's the other thing about it as well. The uptake is quite positive. What we've also done is we've dropped, because we've done the OSI thing, we've stopped sort of focusing on diagnoses and illnesses, right? We're trying to get people to understand that mental illness is a continuum. It's not like you're healthy and you're ill and healthy, this kind of thing. And we're trying to get people not to self-diagnose, leave that up to the doctors, but we're trying to sort of say that, you can go from healthy to ill. It's double arrow, you can go both ways. Pay attention to how your mood is, pay attention to how you're doing, pay attention to your sleep, pay attention to all of these different elements, and basically identify yourself, green, yellow, orange, red kind of idea. So we're actually trying to get people to get fixated off, I don't have PTSD, I do have PTSD. We're trying to normalize reactions afterwards. It's okay to be distressed. It's okay not to be distressed, the whole idea. And what we try to tell our soldiers is, the kind of things that we might do is, because it's consistent throughout, is, after you come back from a mission, it's quite normal to be in the yellow zone. It's quite normal after being in a war zone to be in this kind of situation. But if it persists after a few weeks, doesn't quite settle down, or if you start to move over to the orange or the red, then that's a time to seek help. And what's really interesting about this is, even when I was in Kandahar and sort of what our clinicians are reporting, soldiers are coming in now using the language. They're saying, hey doc, I was sort of yellow, orange, but every once in a while I hit into the red. I just want to come in and sort of get this taken care of. So we're trying to get them away from sort of self-diagnosis, fixating on this thing, either being happy or, did they guess it right? The idea is that, I've been overseas, I'm a little bit screwed up, I don't feel like I'm getting better, I just want to check out what's going on. Social support's part of it, informing leaders, sort of taking the idea that reminding leaders that, there's a health services and chain of command, it's a shared responsibility, for the members. Even when somebody's completely healthy, health services still plays a role in terms of immunizations, medicals, those kinds of things. And when somebody's really sick, chain of command still has a role because they're still soldiers, they still need to be treated. So the idea of the joint responsibility is a really important element of this. Leadership, just again very quickly, lead by example, get to know your personnel. And I think what we're trying to teach people is, again, not to be therapists, but just really old-fashioned leadership principles of, you've got to know your people well, then you'll notice the subtle change, and then giving them the tools of how to have that discussion with somebody and say, hey, I noticed that you've been coming in a little late lately. Is everything okay? This kind of idea. So we don't sort of, have too many cases where we find out sort of after the fact. So it's reinforced throughout the career. The leaders are given the language. They're given explicit permission to have dialogue after a difficult situation. We're doing that. Not critical incident stress debrief, this kind of idea, but really just have the leaders have that, dialogue, that courage, sort of just sit, talk with their people, and actually be good leaders. The other organizational factors, and I think this is the piece where I think research is very important, and I think study your population. Know who's sick. It doesn't always help to sort of have hyperbole and everybody's sick, because I think it can do a disservice, because there's very healthy people that are leaving the military that want to get jobs. And if everybody thinks everybody leaving the military has PTSD or is angry or is dangerous, then it's going to impact them. So sort of have an idea of the scope of the problem that helps with resources. Look to see who seeks care, why do they seek care, why don't they seek care. Eventually find out who gets better, what makes them better. I think the need to have sort of registries and outcomes and all this research is kind of important, and it's not sexy at all. It's very, very expensive, but I think it is important to sort of have these sort of databases and things like this. So what we did way back is, we had our first sort of large sort of Canadian Forces study, and we looked at, the barriers to care, like why are people not going to care, this kind of idea. And until we actually stopped and looked and asked people what the issues were, is the natural assumption was it's stigma, it's the military, you're big tough guys, you don't want to come forward kind of idea. And when we looked at Canada as a whole, because this study was done, there was a Canadian study, sort of the Canadian population, and a military subsection. We found out the vast majority of people that have mental health difficulties didn't come forward because they weren't aware that they had a mental health condition. Right? So I think it's interesting to think about that, because the countermeasure to that is a little different than the countermeasure to stigma, which is, again, very important. But it's kind of like if you think about a 40, 45-year-old person who's feeling a bit lethargic, not enjoying stuff as much as he used to be, a little reduction in libido, those kind of ideas. And they might attribute it, well, I'm just getting old. This is what happens when you're 40 or 50. This is what happens when the idea that this could be a diagnosable illness that could respond to help, didn't come in. So we looked at these kinds of things. And when we look at stigma sort of as a barrier to care, when we looked at the whole population in the CF, 86% of people didn't have an illness, which I think it's important to remember that. But of the people that were ill, sort of the 15 or so percent, the vast majority, 12%, felt there was, so even though by survey, you meet criteria for depression or PTSD or something like this, they didn't perceive the need for care. So I think it's important to sort of understand your population, understand, there's lots of different things that can be barriers to care. And I'm just gonna look a little bit like this. And so what we did in 2001, 2002 is by sort of having our best guess of understanding sort of, what kind of barriers you have, in addition to stigma, in addition to all these other things, is, a lot of people, say, I'd like to deal with things myself, right? And that's a legitimate thing. If you think about it, you've got a rash, you've got an ear infection, you've got things like that. Most people nowadays go on the internet first to sort of say, what can I do about it? So what we should do as organizations is make sure that whatever, if people want to deal with things themselves, let's give them tools, let's give them evidence-based approaches, let's do the kind of things that they need to have. Some people say, I wouldn't know where to go for care, so we educate, let them know. Couldn't afford, not really an issue in the military, in the civilian world, but we can do things like that. Nothing more would help, they don't believe in their education, so we can improve the care. Afraid what other people might think, confidentiality, education, enhance some of these things. There's all kinds of different, some people don't go because they're afraid they're going to lose their job, which is quite a legitimate thing. So education, make sure transition programs are in place. So understanding the population, trying to continue to understand and put those measures in there. So lots and lots of different programs that are out there. In Canada, it's kind of a big, mental health's a big thing these days. That's Clara Hughes, one of our famous athletes that's won Winter and Summer Olympics as a skater and a bicyclist. Bell is Let's Talk is a huge campaign sort of across the country. So the anti-stigma, the education, all that stuff is really big right now, which is part of my reason for optimism, because it's not just about the military right now. We're just one organization amongst many that are dealing with this. And hockey, of course, is big. And so we've got, so what Bell loves the military because, hey, if athletes and soldiers are coming forward talking about it, what's stopping other people from coming forward? So it's really an exciting time to be in this kind of work in Canada. I think one of the things that we try to do here is just kind of get the dialogue, get people talking, right? So I don't know if people can read that. I'm right here in the room, and no one even acknowledges me. And and mental illness is the elephant in the room, and that's the kind of things that we try to get people to think about, because people are showing up late for work, they're getting in fights all the time, there's all kinds of different things going on, and everybody kind of knows the person struggling with something. So who's going to be the first to sort of start that dialogue? Who's going to be the first? And what we have in the Canadian Armed Forces now, I don't think there's an organization in Canada that talks more about mental illness, suicide. Sometimes it's almost too much, to be honest with you, but it's talked about, sort of at all levels kind of idea, which is part of how you destigmatize and demystify some of these conditions. So the idea, accept mental health, as part of our life experience, because I'd love to, at some point, talk myself out of a job, right? Because you don't have people flying across, across the world talking about hypertension or high cholesterol in your armed forces or firefighters, right? So at some point, if these could be just like any other health conditions, I think that's what we should be aiming for. Are things working? Are things working for us? I mean, I think they are. I mean, the research is sort of coming along, but we're demonstrating increased confidence, as I mentioned. I've got a couple of slides showing on that, members of the Canadian Armed Forces seek care at much higher rates than our civilian counterparts compared to our own 2002. So help seeking, recognizing difficulties, all the things that we were concerned about in 2002 seem to be moving in the right direction. Wait times, not wait times, but times for presentation are, coming down at an incredible rate where people sort of recognize their difficulties. And, here's our latest study just looking at sort of, 10 years, so post, we've had the war sort of in between in Afghanistan, but we've also had sort of some of our experiences. So our depression rate stayed the same, 8% in our population, which is about, it's about 1 year prevalence, which is about the same as it was in 2002, but it's significantly higher than the civilian population. Our PTSD rate has almost doubled, and that's not really a surprise given this. So that's sort of our figures right now. And this is sort of the whole population, not just people that had deployed. And here's sort of an interesting, interesting slide in terms of help seeking. And I'll just take a couple of seconds to look at this, and just in terms of thinking about the kinds of things that we wanted to put in place. So here we're comparing civilians in 2012, Canadian Forces in 2002, and Canadian Forces in 2013. And this is the idea of seeking services or going to people for help, with certain problems. And you can just sort of see that, the Canadian Forces, is always higher than civilians, and the trend is going up from 2002. So part of what we really want is for people that are having difficulties, whether it's with a family physician, whether it's with a psychiatrist, psychologist, social worker, co-workers, family, friends, across the board, the members of the Canadian Forces are more likely to seek help, within the past year than sort of their civilian counterparts, and certainly their own counterparts from 10 years ago. So things seem to be moving in the right direction as far as we're concerned. I'm going to speak just a couple of minutes very quickly. I was asked also to talk a little bit about sort of research about where we go, and I think, one of the things that that sort of inspires sort of the clinical research is, even though we have lots of great epidemiological surveys and studies, and one of the things, Paul Bleasy is one of the American colonels. I did a lot of the early research in numbers, said, okay, we've sliced and diced this population so much, it's time to start helping them, right? Which kind of means let's put clinical things in place. And for me, one of the important issues is whenever you go to sort of, forums, things like this, whether it's Bell, whether it's different kinds of charities, there's an idea, there's kind of almost a naive idea that just getting people into care is good enough, and I think, as a psychiatrist that's practiced for a number of years, the care just isn't good enough right now. It's not blaming a clinician, it's just the limitations of the science. And when we look at our suicides in the Canadian Forces and in society overall, we have, we actually investigate every suicide in Canadian Forces in detail. We fly a psychiatrist and usually a senior medical officer, and just dissect the case like crazy, talk to family, this kind of idea. But we find that it's about 50% of the people are in care. So of course it's important to get people that are struggling into care, reduce the barrier, stigma, all these kinds of things. But I think we also need to look at sort of the treatment programs that we have, do the evidence, invest in sort of investigating in things. And so we've created sort of a few different ideas in terms of research, and the three. So we've got the epidemiological research, which is all the numbers, the slicing and dicing, looking at who's sick and who's not sick, and all this stuff. But then we've got three thrusts in addition to that, which is sort of trying to understand the biological underpinnings of these illnesses, trying to find out sort of what's actually happening inside the body, inside the brain. I mean, in some ways it'll legitimize it, sure, but more importantly, to help us sort of diagnose it more accurately, to help us to treat, to help us verify that the treatments are working. Leveraging technology overall. I'll speak a little bit about that. And then the whole idea of personalized medicine. The idea of, when you have cancer, when you have a lot of other illnesses, people are able to do biopsies. They look at the type of cells you have, and they customize your treatment based on your illness. in psychiatry and psychology, it's still very much sort of a black box. We still don't know which treatment's going to work for which person at this time, kind of idea. So it would be nice to sort of, move forward. I'm just going to go through these slides fairly quickly. Biological underpinnings, as I said, there's neuroimaging, there's biological markers, those kinds of ideas. Leveraging technology, and a lot of it comes down to computing, comes down to the ability, and whether you're talking about things like neurofeedback or even video-based, telemental health and being able to reach sort of far communities, reach far forward soldiers, those kind of ideas, using as much technology as possible, getting away from this old-fashioned, make an appointment, come to my office, this kind of thing for every single person that we do. Personalized medicine, we've talked about trying to understand sort of who responds to certain treatments, whether it's medication, therapy, who doesn't respond, trying to sort of, work towards, predicting this instead of that trial and error. And I think what happens is quite often we forget, in medicine, we have hundreds of patients, we're doing these trials, but I mean, you've got to think about what the failure of the trial means to a person. And I spoke earlier about the guy that sort of invented the OSIS, the peer support program, and he and I used to have lots of debates over the years. And one of the things that he said to me is, he goes, the problem is you think like a healthy person. So once in a while, I want you to think like a sick person. And every once in a while, when we're having debates around the boardroom, I'll bring that point up because if I'm depressed and I'm hopeless, nothing's going to work for me. There's not going to be, I'm the guy that, it's the 5% side effect's going to happen to. What do you think failed trials of medications do to that person, right? So yep, it figures it's not going to work for me. And so the optimistic doctor is smiling and say, well, let's try this other one, let's try this other one. So if we could cut down some of that trial and error, I think that would move sort of the field forward. And we're understanding more and more about the types of illnesses that we have. This is some of the work from Sandy, and sort of looking at sort of the electrical activity of the brain seems to not be in as much sync as it is in PTSD as sort of other folks. And I think this is all sort of moving us towards sort of understanding what's happening in the brain and hopefully leading for more sort of conclusions. Technology, the machine, we're kind of in Canada excited by this this MEG machine, which is sort of like capturing the brain waves as people are actually thinking about things. And traditionally, a lot of the research has been done with the MRIs. And part of the reason that we're excited about using machines like the MEG is that it's almost instantaneous. So when you're asking somebody to think about a trauma, to think about Vietnam, to think about that day you lost your buddy, we're capturing what's happening in the brain right at that immediate moment. In other modalities like fMRI, a second could pass, which is a long time when it comes to sort of, where in the brain things are kind of. So trying to understand where things are to sort of tailor, diagnosis, treatments. We're doing things like transcranial magnetic. So there's a lot of interesting, the theme, a lot of it ends up being the electrophysiology and sort of what's happening in the brain electrically. So, magnetic stimulation is one of the kind of approaches that we're doing. Looking at biomarkers we talked about to try to understand things. I mean, the holy grail, which a lot of people want to figure out, is the predictor of the risk of these illnesses. And I think that's going to be very hard. In countries that have human rights, you raise the risk of somebody from 3% of having an illness to 6%, they're going to say, how do I know I'm not the 90% that's going to be healthy? But I think it's the last two that I think are quite exciting, looking at sort of the marker of disease and the marker of recovery. And I think if we can get sort of work on this idea, because leaders want to know, is my guy sick, and is he ready to go back in the game, right? Think about sort of the sports analogy there. So I think as we move forward, I'm just going to go through just very quickly in terms of we're involved in lots of different biomarker things like inflammation, stress, all the different kinds of things that go on in the body when they're exposed. When we look at sort of veteran populations and long term, I mean, the joint pains that they tend to have, the more physical complaints that they have, sort of looking at what happens inside the body long term as we follow people. We're looking at neurofeedback as well. Is there a way of training the brain to sort of, to self-regulate, and this kind of idea, sort of an expansion of the biofeedback idea? Are we helping people to sort of stay in that optimal zone? We talk about in PTSD, some people are zoned out and just sort of numb, and some people are hyper, and this kind of idea. So are we going to be able to train the brain using neurofeedback? I know some of that work has been done sort of in Australia as well. And I think part of what we're trying to understand is it's not really one part of the brain that sort of runs awry. it's the parts of the brain talking to each other. So one part gets scared, the other part says, hey, I'm sort of, you're okay, you're home now. We want to make those connections stronger, and maybe some of these treatments will help in that way. We're looking at virtual reality. We're playing around with sort of looking at this, and whether or not it's better than traditional therapy, isn't really the biggest issue. It's we want sort of soldiers to start doing things that appeal to the younger generation, and this might be a little bit cooler than coming and sitting and talking for an hour and a half to a nice, well-meaning therapist kind of idea. So looking at more and more of these things. We've done some interesting things. We're working with the Dutch on this thing called 3MDR, which is sort of, adding motion, adding a treadmill, having people walking and while putting their traumatic memories in front of them. So the idea of sort of changing things around a little bit in terms of the approach, we're working on that. Personalized medicine, I couldn't find a picture of a soldier, so I thought I'd find a cute kid instead. But the idea of, again, it goes back to electrophysiology, looking at sort of EEGs and maybe predicting with a baseline EEG what medication somebody might respond to. There's more and more work being done there, so we're looking at sort of working towards that area. There's also the pharmacogenomics. Lots of work has been done in genetics, looking at sort of the liver and things like that in terms of, again, if we know the type of liver profile you have, we might be able to predict what medication you may or may not respond to, try to get away from, some of that trial and error. And I'm going to finish with the last couple of slides, and I think, I'm going to just say a couple of things. Like listen to your experts. I think, in Australia, you're blessed. You've got sort of, you've got people like Richard Bryant, you've got Sandy McFarlane, Mark Kramer, David Forbes, the whole group, and I mean, you punch way beyond your weight. So look within yourselves to try to understand. The next point is don't listen to your experts because listen to the lived experiences. I think one of the things that I've learned, I mean, medical training is very patient-centric, this kind of idea, but listen to the spouses, listen to the families, listen to the members themselves, and just kind of, try to get an idea of, don't assume for them. Why aren't they coming for care? What's helpful? This kind of idea. I think there is sort of room for that kind of thing. And there's also, the other experts are the leaders, the people that actually, you work within organizations, so like occupational medicine, talk to your leaders. What do they need to know? How because they're not bad people. They just don't have enough information sometimes about sort of case by case. So, the culture has to change, and I think it's if we go too narrow down the foxhole of clinical research or biological research, the culture actually has to change. So encouraging help seeking, understanding. And we had a great discussion yesterday about pilots, and would you rather have somebody that's depressed, that's not sleeping well, that's sort of quasi-suicidal flying your plane? Would you rather have somebody on medication that's actually doing quite well? So I think the idea of that paradigm shift of how we look at mental illness compared to other illnesses, needs to sort of be looked at. I've sort of talked about this already, but understand the issue, understand the scope of the problem, how many people are affected, why they seek care, why they don't seek care. Understand the barriers, and I think that, like. We're going to have a talk later about stigma, and it's a huge problem. I don't mean to diminish stigma, but it's don't assume that that's the only barrier to care. If you have a mental health clinic on a base where it's a training base, and the soldiers can't take time off during the day, or they'll be returned to their unit from their course, you've got to have after hours available. You've got to have 1-800 stuff available for people. You've got to have this kind of idea. So understand what's stopping people from getting care, because there's structural barriers to care as well. Be really, really careful. I mean, I'm not trying to, preach, but it's our Canadian lessons learned, really, more than anything. Be really careful with the flavor of the month. The person so I get probably a letter a week from somebody that's found the cure. All you need to do is this and this, and people are going to get better. I mean, it actually takes time, it takes research, and the soldiers and the people that are suffering actually deserve sort of, proper evidence-based treatments for these things. And research will be the key for that. And the other point, I like the whole of nation response. Like we're in representative democracies. I remember I was in Halifax once, and I was asked to speak, and it was a philosophy class, and I don't know what I was doing in front of a philosophy class in uniform kind of thing. And purple-haired kid in the third row kind of said, like when you guys go to war, this kind of idea. And the professor stood up and he gave a beautiful response. He goes, hang on a second, do you really think the military picks wars? We're in representative democracies. The people of the country vote for a government. The government sends, on your behalf, the military, to fight this war. So when we come back, it's the whole nation that has the responsibility to look after veterans and to look after things. And I think that that's one of the things that in Canada, I think we have sort of, gone to that point. And I think what that is, though, is that's an opportunity. It's an opportunity for government, academia, the private sector, and philanthropy to all work together. And I think that's the win-win of it, because there's room for everybody in this space. And so instead of finger pointing, there's things that governments can do. There's things that charities and philanthropic organizations do. And there's some things that only academia can do. And so in that case, let's give the academics some money and step out of the way and let them just sort of do what they do best. And the other thing is you need a long-term approach. I think the idea that this is going to be a self-limiting problem to a couple of years, I think, again, that's the lesson that we need to learn. In all of our countries, after World War II, the claims for mental health difficulties were continuing to rise right up until World War II. And then they got sort of lost in the storm. So the numbers are going to continue to go up. And when we look at sort of our numbers, just sort of our PTSD mission from Afghanistan, we often quote sort of the 13, this is all mental health illness, about 8% PTSD, at the 4-year mark, but the numbers sort of keep going up. They go up for quite a while before they level off. The longer you follow people, the more cases are going to sort of keep coming up, as I think Tony so eloquently sort of told us this morning. These things affect people for a long time, and it's not something that is necessarily a diagnosable illness, but you think about what we ask our young people to go through, it's going to have an impact. Canada, we have this very strong tradition with the Dutch, and our veterans go, and I think that's, people know that Dutch women, on average, are Richard, I had to talk about a woman at some point, but, Dutch women are taller than the average women in the world. They're the tallest women in the world. So that's a Dutch woman there. And there's the Canadian soldiers. But I'm struck by the face, by how people are still impacted by things. It's not necessarily disease, not necessarily PTSD, not necessarily depression, but the fact that these things impact people for a long time, and probably even the next generation, is something that we have to keep in mind, that it's not going to be a quick fix, and people are going to present for sort of, for years afterwards, whether we're celebrating them, trying to remember them, these kinds of ideas. And I'm going to stop there. Thank you.